So Mehdi, can you hear us?
Yes, hi Suresh, how are you? Thanks everyone for what a session. We are going to tackle a SFA and a complicated case, and was very timely to hear Bruce, Mark, and Alec, and John, and everybody. I have here my that I've on a Sunday to help us give Ruth, Janice, and two of my fellows are going to be with me. Dr. Agarwal going to present the case, and Dr. Goodman. So without any delay, let's go to the case. Dr. Agarwal is going to present the case. Then after that, we'll start.
First slide. So this is a 64-year-old woman who comes to us with Rutherford class 6 critical leukemia. She has past medical history, diabetes, is relatively uncontrolled, hypertension, hyperemia, active smoking, remote history of EVT, who continues to get put in, recent admission, MICU for MRS step. These are the pictures of the ultra left extremity against marked tissue loss. Next slide. But no evidence of any osteomyelitis on the X-rays. This is the PVRs. Again, you can appreciate significant degree of diminution in blood flow. The APIs were 0.44 with very little flow. The next slide. These are the angiograms that have been performed a few days ago. You can see that iliac are good with the disease. Next slide. There's some moderate disease in the SFA, but you can appreciate that there is some venous flow that can be appreciated next to the SFA, which becomes a little bit clearer in the next angiogram. Next slide. And here you can appreciate that there is complete occlusion of the SFA. It gives a sense that there may be even tandem lesions, and there is some sense of that venous flow, again, likely from AV fistula. Next slide. Very severe disease below the knee. Next slide. Looks like two vessel runoff. Next slide. And a good DP that can be foot, which can potentially be used for retrograde access if we need it. Next slide. So in summary, there are tandem CTO lesions in the SFA in the mid and distal segments, severe diffuse disease of the proximal AT, total occlusion of the with distal reconstitution, and there are large AV from the SFA femoral veins, along with what appears to be multiple AV at the level. Next slide. We have an integrated sheet and over a 7-fringe system in the right CFA. We are ready to retrograde access in the DE if we need to, due to ambiguity of the proximal vasculature, and we likely use BCB with or without atherectomy, depending on how the case goes.
So Mehdi, you have already... Mehdi, can you hear us?
Yes, please go ahead.
So what I'm saying is that you already have a retrograde sheath from the other side, so it means you're going to go endovascular, but given the fact that we had a very, very nice discussion about approaches and strategies to deal with these cases where there's also an AV fistula, which is, I believe, is spontaneous, traumatic. Did you previously attempt this case? Because this is highly unusual to have such extensive fistula.
Yeah, I'm glad you asked me those questions, and honestly I'm interested as to what the panel thinks. But the patient has not had any prior trauma. A CT scan was performed. We could not identify fistulas in other locations. She does have some lower extremity swelling, to be honest with you, actually moderate in size. I don't know if you could have appreciated that from the pictures that were provided. But we did discuss the case as to what the best approach would be for this patient. And given her comorbidities, this extensive edema, I felt that an endovascular approach may not be unreasonable, because the occlusion itself is honestly very short, and I will show you better pictures now so you can see the occlusion. The main issue is the fistulas and how to deal with that, and I am not sure a bypass would deal with that or not, so I'd be interested as to what the panel think. Our approach right now is that we're going to try to cross this lesion while you guys discuss the case and give us some advice related to the AV fistula and what we should do.
So I'm going to go down the panel right from my right all the way in using what you just said in the prior presentations, your strategy and the factors that would contribute towards deciding on the strategy itself.
So I think this is a very interesting case. I'm trying to understand about this fistula. And it's very unusual to have a fistula without any prior intervention. And the question is this a one localized fistula, or are there multiple connections? It's hard to see from the images. If there are multiple connections, you'd have to worry about an atriovenous malformation, and you may want to do other studies. I would certainly start with a duplex, maybe an MRI as well. It's highly unusual.
Dr. Manzi?
But from the imaging, it doesn't seem to be in a high flow. There is a return, a venous return, but it's not so high. I think there is not a Stilling syndrome in below the knee, so evident. So probably I would evaluate these fistulas after the first SFA recanalization up to the popliteal artery, and deciding if there would be a Stilling syndrome for below the knee or not. This is, I think, important for the patient.
So Bruce, your classification scheme, where does it fall? And what is your decision in terms of endovascular or doing some more imaging or surgical approaches in this case?
Bruce, before you answer, can I show you some better pictures here? I
Sure.
think we have some nicer pictures. So this is the picture now. Excuse me, right here. So we put the sheet into the SFA, and basically the lesion, if you will, it's right there is about 15 centimeter. The reconstitution is right at the level of the Hunter's canal. There is a collateral right near where the occlusion is. And then this is the popliteal area. I think this picture is a little bit better than the other ones. You can see the pop reconstitution. There may be a fistula down there. And then going down, we have a better picture here. There is some proximal AT disease and TB disease. You need to get down and get a better picture of that. But it seems like there is some proximal disease. Just wanted to show that. Go ahead, Bruce. I'm sorry.
Go ahead, Bruce.
I don't see any problem with approaching this endovascularly. It looks like a relatively short SFA occlusion. The popliteal artery is open, and I believe that these fistulae will look a whole lot different once that SFA is open. It seems like the profunda is having some contributory effect on it, perhaps. We'll see what it looks like after it gets angioplasty, but pretty decent runoff above the knee. I think it still fits. Now the heel necrosis is the kicker, and looks like there's pretty significant heel necrosis. So if there's good single segment saphenous vein, you could make a very good case for bypassing it, but you'd still want to go to a tibial artery, I suppose, now that we see a little bit better picture there. So I'd still approach this endo first, I believe.
Thomas?
Can I get
Yeah,
a back?
same. Well,
Yeah.
endo is the only option to solve the problem, including the AV fistula, which is most likely of congenital nature. And it will be interesting to see how much reflux we will see later on after recanalization. And the endo approach, if the SFA would be the source of the fistula, would then be pretty easy. It's implanting a wire band, and with this you could solve both the occlusive disease and also the fistula. The fistula is definitely of significance at the moment, because in the last image we could nicely see the venous return flow down to the calf level. So this is resulting, or it's probably the main reason for the swelling of the patient. So both has to be fixed, the arterial occlusion of the SFA and the fistula as well.
John, your comments, Mehdi looks like has already crossed it. So your comments regarding the strategy and also how would you finally treat it?
Yeah, I think it's a great case. I think the fistula really made the disease look a lot worse than it actually is, because most of the flow was going into the veins rather than down the leg, and it's a relatively straightforward fem-pop lesion, and then there's a significant infrapopliteal disease that needs to be treated both in the AT, short segment occlusion, and some severe disease in the PT. So I would treat it all. I think normally we would start with a drug-coated balloon for the SFA and then selective stenting as needed. In this case with the fistulas, maybe a Viabahn, as Thomas mentioned, and then we would treat pretty much every vessel we could below knee and try to open everything up and maximize the chances of healing since there's such significant tissue loss.
So Thomas, because you mentioned Viabahn, my question to you is that do you see the reason to use DCB here or just go with the regular balloon and Viabahn following what John said, saving some cost?
Yeah,
dollars?
well, I would start with pre-dilatation with a sufficiently sized plain balloon in order to establish flow through the SFA and then to re-evaluate the location and significance of the AV fistula. And depending on that outcome, then I would decide how to proceed, whether using drug-coated balloons. If there would be multiple AV fistula present, I would not use a DCB, probably except landing, potential landing zones of the Viabahn, but then I would go directly to Viabahn implantation. If it would be a localized AV fistula, then you can proceed with DEB and with occlusion of the fistula by coil embolization, for example.
So Mehdi, you heard what the panel is
So-
saying, so tell us what's your
Yeah.
approach?
Yes, so honestly, I think John hit it on the nail. I think the prior angiogram didn't do justice in a sense that we thought that there was much more disease there than what we found this morning when we did the selective angiogram of the SFA. So I think that's one teaching point here is that in these cases, you need to really get into the SFA. You need to get, if the SFA is occluded, you need to get to the profunda. And you need to really take good pictures so you can understand the disease. I think that's the first teaching point for me. The second point is that I agree with everyone. I think that my plan was that I was going to do angioplasty and then take some pictures and then decide as to how we want to proceed, at least with the SFA. Given the swelling that she has and the AV fistulas, I think Viabahn is very appealing. So I think let's take a picture now. We just crossed for the people that are in the audience, we used the Navi Cross 035 and a stiff angle glide wire. It was actually relatively easy to cross it, as you all saw. And we just did a balloon angioplasty with a 5 by 150 balloon. So I'm now going to take a picture, leave it there. I'm going to take a picture and then we can make a decision as to what we think. My original plan was that the fistulas were not significant. To do honestly atherectomy and DCB, we have actually the laser machine here. But I think given the fistulas, we have to change our plan. So we are very interested as to what you all have to guide us with.
So Bruce and Dr. Manzi, take the Mehdi on and let's give him some feedback of what we think. And given the fact that the new pictures definitely do show that the fistulas are more diffuse in nature and not localized to a particular area. Bruce?
I think I'd still like to let him finish the pre-dilatation adequately so that you then get a good selective shot of the SFA and kind of see where the connections are and how many and whatnot. I had originally thought Viabahn made a whole lot of sense too because you're not quite concerned about closing off future opportunities to embolize something because you got a pretty good profunda there that if you had to get to some branches.
I just want to preempt before the picture and ask our surgeon here. So if the connections are beyond the site of occlusion, so are we going to also cover those areas with the Viabahn?
Well, as long as the connections are limited to the SFA or popliteal, again, I'm trying to get an understanding of what this is all about, whether this is just there's something else going on here.
Sure.
Or whether this just, a person who's had several spontaneous fistulas due to plaque burden and that sort of thing. But yes, you can certainly try to cover all the fistulas if you can with the Viabahn.
So Dr. Manzi, does the presence of the fistula and the location, like Alec mentioned, weigh in on your decision of how would you finally treat this?
it's still my conviction that probably after a prolonged definitive dilatation with pre-dilatation with a 5 or 6 millimeters balloon prolonged, we could evaluate much more better size of fistulas and the grade of stealing of these fistulas to decide if we have to cover or not with a long Viabahn or something else, or we could remain on conservative treatment with atherectomy or with drug-eluting balloons alone. It would be interesting to see the new distribution in terms of pressure and speed of flow in SFA towards below the knee vessels after the definitive dilatation.
Thomas?
What I was going to do is that I'm going to leave the balloon up here in the SFA, and I'm going to take a picture
That is exactly
from
what
the
we
common
suggested.
femoral and see what happened here. So I'm going to leave the balloon there. I think this may not be a bad idea to get a sense of what the profunda is doing.
I think that is
So
exactly
Cine-
the point. That if there are fistulas below the knee that have an impact on the treatment plan. And Thomas, do you agree with this strategy of occluding the SFA and then taking a picture to make sure that there are no multiple points of communication below the knee?
Well, if you would like to identify deep femoral artery areas or branches that contribute to the fistula, then it definitely makes sense. Here it seems that there are also some more proximal located origins or sources of the fistula. So this is going more into the direction of a multi-level fistula, which then needs to be treated with the Viabahn. So selective embolization is not very sufficient here. It seems that below the knee there is no additional fistula. It looks like more a retrograde flow coming from venous insufficiency. And that would make it easier to implant the Viabahn.
Take this picture.
So John, looking at this picture, looks like the communications are probably slightly more proximal, is that right? Because you release the balloon more proximally, there's more filling of the vein. What do you think?
Yeah, I'm still a little bit confused, quite honestly, in terms of where all the communications are. I think there's multiple, and that they're not really distinct or discrete. So it'd be nice to see what things look like once all of the stenotic lesions are open as well, and there's less resistance to flow in the SFA, as to whether some of those communications will become less obvious. So after the first balloon inflation, he didn't really treat all of the disease in the SFA and popliteal, but once he does and there's less resistance to flow, it'll be interesting to see what it looks like.
So you would at this point stent the stenotic lesion with a Viabahn and then take follow-up pictures?
Well, I'd like to see what it looks like after everything's been effectively ballooned, for one. I suspect the fistulas will still be there, but they'll be less prominent. And then I think we're going to need to do a covered stent.
So now the balloon now is at the knee joint, as you can see, and there are still some fistulas. Some of these may be coming from the profunda. It's really hard to say.
Yeah, but Mehdi, you did a selective angiogram after you crossed the occlusion of the proximal proximal below the knee arteries, and there it was nicely visible that there had been no additional AV fistulas. There was simply reflux in the venous system coming from the high pressure from above. So in this area, there is no additional AV fistula below the knee. If you recap these images, then you will see it.
No, I agree with you. That's why I showed that below the knee picture when you were discussing it. I agree with you. I think that the likelihood of finding too many fistulas below the knee is low. What I'm going to do at this point, we all agree, and I'm going to put a couple Viabahn. And the question is where to start the Viabahn? Where should we start laying the Viabahn?
So let me ask the panel. Alec, you have a comment, and Dr. Manzi, regarding the location of stenting, or you have other imaging suggestions?
I was just going to ask whether or not you were considering to do a selective shot of the profunda to see whether in
I
fact.
don't think that's a bad idea. We can actually do that. Give me that Navicross. Let's do that. I think Dr. Farber has a good idea.
And Dr. Manzi has another suggestion. Go ahead.
No, it was possible to remove the wire from the balloon, inject through the balloon with the balloon inflated to see if there are other fistulas in the below the knee area.
I'm going to get a selected picture here next to the wire we have in the SFA. I think it's worth it. I think this case is interesting. It's not so much the intervention, but rather these fistulas and dealing with this. And we have all you guys there, which makes it wonderful. Let me just wire this profunda for a second floor.
So how many of you have actually seen this before? To be honest, I've been doing this for a little while, and I have not seen spontaneous fistulas in the SFA before. Alec, have you?
So I really think that we're dealing with an AVM here.
I see.
And I think the answer will be once the stent grafts are placed and a shot of the profunda is performed, if we see continued fistulations from the profunda, that'll be the answer.
I see.
And then I would think that may need to be embolized.
In addition to the covered stents right now?
Yes.
Okay.
I think if you place a covered stent here and you still have a lot of arteriovenous malformation or AV fistula, then you're going to have deferential flow away from the SFA and be maybe more likely to thrombose the viabond. So we really want to deal with that.
I think for me, what Thomas said is very important, is to know where the location is. And Thomas, can you comment that if you do see, for example, and someone is doing this, and you do see multiple points of communication, in this case, would you then cover even the near non-occlusive segments of the SFA and put covered stents all the way through to cover every point of contact in the SFA? Let's assume it is just in the SFA and not below the knee.
Well, of course I would. If we would have multiple origins of AV fistulas, then I would treat the entire SFA with a wire band. Well, because the artery is diseased from the very beginning down to the conjunction to the popliteal artery. And what would be of additional interest at the end, now you can see there are multiple fistula also originating from the deep femoral artery, what could be expected if we consider this as AV malformation. So of course this raises the concern that more flow will be directed into the deep femoral artery, resulting in a reduced flow into the wire band. But on the other hand, I don't see another option, because we have already seen a lot of fistula also coming from the SFA, so we need to treat those as well.
So Bruce, you see this is a popliteal injection, and you
Yeah.
do
Yeah,
see
profunda.
a profunda injection, and you do see some filling of the vein. So does it change your treatment plan right now, or you just keep going right now and put some covered
I'd
stents?
still like just a selective shot of the SFA after angioplasting
see.
it, and then use that information to
Okay.
make a
I'm going to
decision
give
how much
Bruce.
to cover.
I just remove this from the profunda because I think we got our answer from the profunda. So let's give a selective shot of the SFA here. So I'm going to push the sheet down a little bit here, so we are selective in the SFA here, right in the SFA. And
What would be nice, Mehdi, if you could occlude the deep femoral artery with a balloon and then inject again contrast, so that we can see the distribution of fistuling between SFA and deep femoral. So what we would like to see here is a complete pre-dilatation of the entire SFA, then block the deep femoral, and then we will get an impression how much shunting is coming from the SFA.
So Dr. Manzi,
so we have already pre-dilated the SFA with a 5-0 completely.
But there's still a significant residual stenosis, or isn't it? Yeah.
There is some.
There are some areas where you obviously did not dilate the lesion.
Let's do it again. We'll do it again, but I think it's interesting because that profound. So, Alec, can you tell us how would surgery? This is the 250.
Alec, this is a good question.
Man, situation. I guess my question is that if we don't deal with the AV fistula, you would be offering this patient a common femoral to below the knee bypass. Is that correct?
No, if I weren't doing this endo, then I would do a femoral to AT, distal AT bypass. And this way you wouldn't have to
Distal
deal with the
AT.
AVM. But if you're dealing with the AVM, which what you're doing right now, I think you're going to have to probably consider embolizing some of the branches from the profunda once you put the stent graft into the SFA.
Is there an option of, say,
That's what I was
proximal
thinking,
ligation or
but-
something? No? Surgically, if you do it?
I think dealing with arteriovenous malformation surgically is extraordinarily difficult. I think a lot of those cases ought to be done endovascularly.
John, you made a very interesting point that any residual flow through the AVM could affect patency of the treatment in the SFA. Could you elaborate on it? And I think it'll be a great discussion for the entire panel to weigh in on this.
Well, I think particularly when we're talking about a covered stent, where flow through any kind of a prosthetic bypass or a covered stent flow is really important, good flow. And if you have, deferential flow down the profunda femoris because of the AV fistula, then that viabon is going to be more prone to thrombosis, and then you're going to really have a tough situation.
So Thomas and Bruce, do you agree with this? Bruce?
I certainly do, and certainly patient compliance with medication is something that we need to take into account before we know exactly what we'd want to do. So somebody that won't take their medication or can't take their medication, much more likely to have complications with a covered stent.
So Dr. Manzi, imagine he places he dilates the lesion and you still see differential flow. I think Thomas's suggestion of occluding the profunda and then injecting probably makes a lot of sense because that is going to have an impact on the patency. How do you feel?
Yes, I completely agree with Thomas. Right now, the preferred flow is into profunda, and we continuously see the filling of the vein. So probably we should make a test occluding the profunda and having an injection directed into SFA and popliteal tract. Probably this could help to decide finally.
So prior to placement of the first stage of viabons. So Mehdi, are you, this is a suggestion from the audience, and do you have the provision of actually doing that right now? Of placing a balloon in the profunda, occluding it, and then doing an injection selectively in the SFA after you have well dilated the lesion. Is it possible through the caliber of the sheet you have?
I'm going to do this one first, if you don't mind.
Sure, sure.
We have now an ostium of the SFA, as you can see. So the whole SFA now has a balloon, and right at the ostium, I'm going to take one picture now. At least, I think Dr. Gray wanted this, so Farooq.
No.
I think it's
You've
a
already
reasonable-
got that. You already had that picture when the
But I
SFA
had
was
that
occluded.
one-
Yeah, you already had that picture when the SFA was occluded, your initial shot. So it makes more of a sense of when that SFA is open. See, this is just showing you, you had profunda contribution from the start. What you're just assessing is what is the SFA contribution to it. That's what we're after.
But just to complicate things further, Bruce, whenever we dilate the SFA and we create dissections, you open up little communications between the artery and the vein. You'll see like little mini AV fistulas after you dissect an SFA. So that's going to further complicate the assessment here. I think either way, it's going to look like there's an AV fistula between the SFA and the vein.
Well,
I think you got to treat it. I mean, I would just treat it with a covered stent and then probably consider embolizing whatever you need to embolize in the profunda.
But if there would be major AV communications now coming from the SFA, you could distinguish this from balloon inflation related minor communication. So that it would be really interesting to see what's the
I'm going to do it. I'm going to do it. Thomas. I'm going to put a wire right now. I actually took out the wire. I shouldn't have taken it out. I'm going to put a wire here in the profunda, and we put a balloon in there, and we occlude the profunda and take a picture. I think it makes sense.
Sure.
Because I get your, Bruce's point that SFA was occluded, so we already know that some of these fistulas are coming. Go down. Some of these fistulas. Give me that. Can I get an 018? That.
I think I also want to raise while we are discussing this and Mehdi is proceeding is the embolization of these AVMs is not an easy task because as you keep coiling, sometimes you see newer areas of communications open up. So it is not a very simple thing to do is to keep coiling communications of the vein from the profunda. It is a highly difficult task, and I think imaging would be a very limiting issue as we continue down this path. But I think this picture is going to be very revealing, Mehdi, and we are all awaiting it anxiously.
Yeah, do it. Take it this. Come back down.
So what do you have right now? You have a balloon you're wiring the profunda right now?
I took the wire out, unfortunately, and because I thought we were done with it, so we rewired it again now.
Okay.
We're going to put now. I'm just in a branch. Can you give me a torch? Come down a little bit.
You may just have to occlude it proximally,
Yeah, just a 2 centimeter long balloon.
Right there.
just proximal.
Then. Yeah. So that's okay.
A little bit more.
There you go.
You know, I do want to invite the audience to jump into this because this is extremely intriguing. I think you do have microphones. I see Craig Walker, I see Dr. Burkhardt, I see Andrew Schmitz, and many others. So please feel free to jump in with your comments and suggestions, and I think we all will be enriched by this discussion. Dr. Walker, do you have any comments? There's a microphone right in the middle.
There.
Go ahead.
Yeah, I think you could get some extra information here by using a small wire and using an 035 base balloon, and with your balloon inflated in the SFA, take serial angiograms as you come back. That would give you an idea. It would be the reverse of what you're doing now, but it would show you if there's an SFA AV fistula. It would show you where it is. I think this is very important in this case, because if you're talking about placing a Viabond in someone who already has very poor outflow, because this patient has quite poor outflow, it's very important to try to figure out what you're doing.
Great point.
That was correct.
So Mary, you heard that
think that was-
suggestion from Dr. Walker too?
It's a great suggestion, Del. And, that is a good point. I mean, we can put a balloon down and I suggestion was to inflate it, is that correct? And then inject from the lumen? Can you tell me what he said exactly?
I think that is exactly what he's saying, is to place an O14 wire in the SFA, take a 035 balloon, so you have a bigger lumen to inject, occlude the balloon proximally, and then inject through it. Dr. Walker, is that correct? That's right. I represent him very well here, so go ahead. I think that would be the next step, and that would help you localize communications from the SFA, because if any one of us want to suggest embolization, let me tell you, I've done a few of venous embolization. I find it far more complex than what it appears to be when you start, because they keep popping up when you keep embolizing them, and I feel very, very unconvinced at this point that we know exactly what we need to embolize. Anyone else, John?
No, I think more information's better, clearly here. It's a complicated case. I think that, the embolization procedure is going to be a full day's work in and of
Exactly.
itself. So
Exactly.
probably that's not going to be
Yeah.
something you're going to be able to accomplish today after treating the SFA.
Dr. Burkhardt, please.
Up on going up here on the profunda. Okay. Go up
Please-
here. It's
please
a 5
continue.
balloon.
So I just wanted to make the case that although this case may be one that nobody sees during their career, the whole concept of this steal from an artery to a vein is really important to keep in mind when you're doing critical limb cases. So one of the scenarios that can happen is if during a popliteal puncture, for example, you induce an AV fistula, and you have tibial disease, you'll also induce steal, and you'll also make things worse.
This picture is very revealing, and I think that this actually does tell me that there is a good chance that we could be successful, and the amount of flow, at least in my view, from the profunda is much less now. And I think, what does the panel feel? Alex, start with you and give a quick, short comment of how do you assess this angiogram?
Can we see a little bit more distal? That'd be nice to see the rest of it.
Go ahead,
Let
Alex.
me put
So
it higher. I don't.
It seems like when the balloon is up, there's not a lot of fistulous flow that suggests that the fistula, or the majority of it, is coming from the profunda.
Perfect. Dr. Manzi, you agree?
Yes, of course. I thought after the definite dilatation in SFA, with the occlusion, you can see that there are no many communication from SFA. So the The stenting with the Viabahn or cover stent could be delayed, I think.
Bruce, ready for stenting in the SFA or not? Not yet?
Yeah, I'm not sure that
Because
SFA
I
contribution
could-
is significant. I really appreciate the comment of compromise runoff and how that may change your threshold to consider. And this is a non-table
That's right.
decision, it's all relative. Do you think it's bad enough? I'd say I'd probably just use a nitinol stent at this time, looking at that contribution.
Thomas, this was your suggestion to begin with, so how do you rate it now?
Well, there is simply one branch, which was the initial collateral branch taking off at the middle part of the SFA, which is providing the fistula with flow, so it could be either covered with a short wire band.
Maybe here.
Yeah,
Yeah.
there is some distal contribution. So basically, it seems as if one wire band would be implanted into the distal segment, should be enough, and we don't need the full coverage of the SFA. So the proximal part could be treated easily with drug-coated balloon. So it could be a combination therapy.
So Mehdi, the summary of our opinions from the panel is that at least your profunda injection was very, very revealing to state that the amount of communications are much less, and they were primarily coming, we believe, from the profunda. So stenting with Viabahn, at least the CTO segment, the occluded segment first, might be a reasonable thing to do at this point.
Yeah.
What do you think?
I agree. I'm going to do that. I'm going to put a Viabahn in the pop, basically, proximal pop and the SFA, and then we'll see what it looks like. We want to go with DCB. I think the occluding the profunda was very educational. Don't you think so?
Absolutely, but I just have a suggestion, personal one. You can take it whatever it's worth. That I would not be shy in the length of the Viabahn. I think you should not try to just nail that segment. Maybe cover a little bit more proximal, not so much distal, of course.
15 centimeters.
So next question. Now that we have solved the most important issue, let's get into the minute details and give you some more trouble and make your life a little bit more complicated. How are you going to size your Viabahn? I'm sure you have addressed this with your fellows many times, but enlighten us, because we can always disagree with you. Go ahead.
Of course, if you disagree, you'll never be invited back. But
Exactly. So what kind of balloon did you use? I think you used a 5.0 balloon. So are you going to IVUS it, or you going to add some cost? I see John Burkhardt, Dr. Burkhardt nodding his head. Not yet, but IVUS is, I think he might accept that charge. How are you going to size your Viabahn, or you already pulled it out of the bag?
I have a 6 here, but I agree with you. The sizing of the Viabahn is very important. On the CT, I measured it. It looked around 5.5. So we could IVUS it, but for the sake of time, I'm going to put the stent. Go ahead.
Go ahead. We'll watch you silently while you place the Viabahn. So you have what length and what dimension of the Viabahn, you said? Can you repeat again?
the
6 by 50 Viabahn.
615.
615. Good. I agree.
So I still have a question.
Yes, please.
Sorry, over here I'm to your left, but up here.
Please.
So here's the question. We've not put a balloon into the popliteal artery to occlude that artery and inject below to see how much, if any, fistula flow is coming from the tibials. Before you go covering all of this and losing access, kind of don't you want to know all of that information? Because if it's the entire leg rather than a short profunda branch, then maybe the ischemia is so chronic that doing all of this, which we're about to do, shouldn't be done first.
I agree, and I'm just going to say my point of view and then let the panel discuss. I think you're absolutely right, but here the question is not, it's an all or none phenomenon, but more the relative nature. So I think my personal view of this angiogram is that predominance of this AV fistulous connection is coming from the profunda. It certainly does not mean that there are none other. So the profunda angiogram did suggest to me that most of it is coming from the profunda venous communication. Anyone else? And Alec, What's your interpretation?
Well, there's no question that we need to, at some point, evaluate the extent of this AVM. No question about it. This is a symptomatic leg, and from what I understand, there's also edema present. So at some point, you're going to be treating that AVM. And yes, the more information you have before you do that, the better.
Anyone else in the audience? Because that's a good question. There could be below the knee AVMs also.
Yeah, but this has been evaluated already with the angiogram after crossing the occlusion, so there was no hint for additional AV fistulas below the knee, at least not at the proximal segment. This did look very nice.
Please go ahead in the audience.
This might be a minor point, but you know that SFA balloon wasn't fully occlusive, so it actually you were still getting some flow down there, which may be showing some flow into that into the venous system. So we don't really know whether there was actually anything down the SFA, primarily because there's still flow in the profunda.
Yeah, I agree. It wasn't completely occlusive.
I agree. Excellent suggestions from the audience. I just would like to ask the audience to just introduce themselves because I don't know all of you. I should, but I will call out the names of individuals that I know, but please feel free to jump in because this is highly unusual, very interesting case, and I think more opinions we have, more trouble we can make for Mehdi, and that's exactly what our job is. So keep going. So Mehdi, are you deploying right now? We can hardly see it. We can see it now.
Right, so I'm going to.
What stage are you in? I'm lost you here.
So I'm doing what the blue is.
Mehdi, you're breaking up. Let me tell you, we can't hear you very clearly. So please let us know what stage you are in. Or maybe one of your colleagues who is wearing a microphone could also add in.
What we are doing here, can you hear me now?
Yes.
So basically no fistula
From below the knee.
no fistula from below the knee. Can you hear me?
You are still breaking up.
Can somebody fix this?
I think going back to the question from the audience, I think this is a good picture that helps you. I think that's a good point.
Yes.
Thank you.
Okay.
So John, this distal vessel is diseased. We are placing a 6 millimeter Viabahn. I'm sure it makes you slightly uneasy. Is that right?
Well, there's a lot of issues with the Viabahn. I mean, one thing is you always want to prep the vessel well, make sure that you can get the device fully expanded because it's not like other nitinol stents where if you're oversized or you're in an area where the vessel's not well prepped, you will get infolding of the graft material and a higher risk of stent graft thrombosis. So vessel prep's important. Ideally covering the lesion entirely. This is an unusual case, but normally if you're going to put Viabahns in, we would treat the entire vessel with a Viabahn, post-dilate it very aggressively, make sure it's well expanded, and also try and avoid geographic miss. You don't want to be dilating outside the stent graft if you can help it to reduce the risk of an edge restenosis. And nowadays we can use, as Tomas mentioned, we can use drug-coated balloons at the edges too to reduce the risk of edge restenosis. So a lot of technical issues when you're using Viabahns. And then the last thing, which we've already talked about, is you want to make sure you have good outflow. So we need to, at the end, make sure we get this stuff dilated below knee to make sure there's good flow through there.
So Thomas, we always learn from Germany how you can achieve good results with low cost. So question to you is, would you use IVUS in this case?
No.
Can you show
To be honest,
my hand?
I wouldn't. In Germany, it's not reimbursed, so it's expensive for the institution. And what we saw is the inflated balloon. We saw the reference vessel diameter, so we can more or less calculate what's the right size here of the Viabahn, and I believe 6 is okay. The vessel does not look very calcified, and if you post-dilate the Viabahn with a 6 millimeter balloon with high pressure, then it should be opened.
Bruce and Dr. Alec, any suggestions regarding imaging before Viabahn, after Viabahn, assess the distal edge, distal vessel? Yes, no?
No, he's already dilated outside of where he's going to implant this, so that's a done deal already. So no, it's just I picked that Hunter's Canal as the main target zone and maybe put 5 down, 10 up and go.
So let me get more specific with Dr. Manzi and Alex. So the edge of the Viabahn is an area of potential concern in the future. DCB for another application of DCB to put an expensive device at the edge of a more expensive device and see if that helps?
I'm concerned about here there is a three-vessel disease. There is no direct flow into the tibial, so the outflow from SFA should be compromised by. So we have to treat, or we decide to treat at least two vessels in the leg to give an outflow to this implantation.
Wire?
Or we have to avoid to deploy a long wire band.
So you would, in this case, go after some of the below-the-knee vessels?
Yes, of course, it's mandatory because we can improve the inflow, but if there is not outflow, I don't think the clinical improvement could be helped in this way.
Alex, this is your two questions for you. One short answer for imaging, and second is, would you, at this point, that you have a decent result in the SFA, hopefully, go after below-the-knee vessels?
No other imaging, and I completely agree with Dr. Manzi. You have to open up the outflow, lest not only do you not achieve healing, which is what your goal is, but you also are at risk for thrombosis of the viabond.
So,
Then
go ahead.
probably, maybe
Edge.
I'm wrong, but if we open up and we give a better outflow to the SFA, the pressure, blood pressure into the SFA should be less, and probably even the potentially residual communication will disappear. The problem, the main flow is from profunda. So a new distribution of the blood flow pressure with a good outflow could be influence really the performance of the fistula.
So Bruce, Thomas,
Suresh,
and
can
John.
you get,
Mehdi, let me
Suresh,
just...
can you hear me?
Yes, go ahead, please.
I want to just tell you a couple of things here because we've done a couple of steps here.
Sure.
We did the viabond, posted it with a 6.0. So I want to show you that, and I want to show you the proximal SFA so we can make some decisions related to that. But then we're going to go below and try to some of the kind of rank have outflow viabond, but so the patient has alter burden.
I understand what you're trying to say, but Mehdi, I just want to mention, we are still breaking up a little bit, but we get the gist of what you're trying to say, is that you do have some flow, you have placed your viabond. The question we are asking here of Thomas and Bruce and John is that will they all recommend going after at least one or two of the below-the-knee vessels to improve outflow? So Bruce, you can take that on, and then Thomas and John.
Sure, I couldn't agree more, because it's been clearly shown that the thrombotic risk is directly related to outflow integrity, and it's a big deal.
So you would go after both of those vessels,
Yes,
I think?
Sure. Well, the tibio-peroneal trunk gives you two.
Yeah.
Two outflow vessels plus the anterior tib. So
There are
you can
very,
address all
very
three.
short occlusions of the posterior tibial and of the anterior tibial, easy to treat with drug-coated or drug-eluting stents, and then he would have a nice three-vessel outflow to the foot. So this is that's what we would do in our institution here.
So John, Thomas just suggested, I'm sure he didn't misspeak, is to open the CT of the posterior tibial and place a drug-eluting stent. So your thoughts? I'm just trying to spice this up a little bit.
Well, I'm thinking about Mark Burkett as we talk about 2 or 3 viabonds and some drug-eluting stents below knee. No, I think we would balloon the below knee vessels. We don't really have the option of drug-coated balloons for the infrapopliteal vessels in the U.S. now. And then if I got a good result, I'd probably leave it. If I got a suboptimal result, I would put a coronary DES into the proximal tibial arteries.
So you would recommend going for the posterior tibial CTO occlusion along with the...
I would open everything up.
You will open everything up?
Everything, yeah. Everything I could below knee, yeah.
So Mehdi, I don't know how much time is left, but you have a charge to go after below the knee vessels, at least a few of them, if not all. What's your thought?
I agree. We are having some technical issues. I apologize. But I agree, and that's what we're going to do. So here's the anatomy here. And We're going to try to open the PT first because of the heel ulcer, but we'll try to address the AT too if we can. Give me that book.
The PT is the shortest, probably the straightest.
I think there's more work to do in the SFA too, but it's nice to get this distal stuff open.
Yes, we have to go back and finish the proximal SFA.
Can you just describe what
I think
wires you're using too?
Mehdi, can you describe the
This is-
equipment, the catheter and the wire?
This is a 018 CXI, and Pilot 200 is 3.5 gram tip.
Perfect.
So as you can see now, I think we have crossed in it. I think we've crossed the,
I think so too.
yeah, we're in the
Yes.
peroneal. Well, that's okay, I guess. Let me see. Yeah. It'd be nice to get to the PT.
You may need to angle your wire maybe a little bit more, but I think it should be okay.
Should have that. We typically, when we work below the knee, we like to be antegrade and have our sheet right by the pop,
Yes.
which we can do. But in this situation, because of time, I'm trying to see if I can just get this. That's okay. Let us do some a little bit. Here, what it,
I think when you open up the TP trunk, the PT will be more
easier to.
more easy to see.
Yes.
Yeah, now I see it. Yeah. Now so let us. I think this is a very nice feature. It takes a couple seconds extra, but it gives us a lot of help. Okay, Floro? Yeah, you can come back a little bit.
Pull back your catheter and direct it into the posterior tibial.
We could even think to deploy a double wire, a double 1/4 and 1/4, peroneal trunk and peroneal and posterior. So when we delayed, if we have a plug shift or a flap, we could avoid to lose one of the two vessels.
Agree. I think he has an 018 catheter, so I think he will have to exchange
Yes, but
that
after
out.
the dilatation of SFA, they can reach with a Berenstein for French catheter, huge lumen and two wires, and
Come down there.
Yeah, I think that's a good point, Marco.
So Mehdi,
Going-
Dr. Manzi's suggestion that a double wire technique might be time efficient also, but you have gone down, I see.
But no, usually it's not necessary. I'm going to balloon this right now.
Sure.
So we're going to balloon it with a 3.0 by 3.0 chocolate balloon, and I don't know how familiar the folks in the audience are with the chocolate balloon, but it's the balloon that has a nitinol cage, and at least we believe that it decreases the incidence of dissection. Obviously, we need more data related to that, but I don't know if anybody else on the panel has used the chocolate balloon or has any comments. I know Dr. Zeller has used.
We have it also, we use it, but anyone else? Alec, Dr. Manzi, do you have these toys? No. Thomas, in Germany?
Yeah, we do have.
And John, I'm sure you do have, is that right?
Yeah, I haven't used it a whole lot, but we do have it. Yes.
So we are in the peroneal. You didn't want to see, which is fine. We'll
That's
get
fine.
it.
I think in the interest of
Let
time, you
us
should
get-
just balloon it. You have 20 minutes left, 25 minutes.
So I have
Subhash,
a question for-
while he's working with the wire, just this case is such a great case to understand physiology, because with the whole issue of a covered stent in the SFA, the issue of an AV fistula is obviously really crucial. There was a question of whether there might be distal AV fistulas, which there aren't, but if there were, they actually, if anything, would enhance the chance of patency in the Viabond. Whereas anything proximal, which is an AV fistula, decreases the chance of patency. Whereas in contrast, stenoses distally obviously really will decrease the chance of this. So it's really a complex interplay of fistulae, stenoses, and where those fistulae lie.
Great point. While we are coming towards the end of this case in the last quarter, the question I want to bring up, and I think people in the audience and the panel to weigh in, that if we leave this patient with residual fistulas, even with an open SFA, what would be the overall effect on wound healing? Because this is not a true arterial problem, inflow problem itself. It could be also a large contribution could come from all the venous insufficiency and the venous communication that is present in the superficial and hopefully maybe in the deep venous system also. So
Certainly, if you have combined pathophysiologies there, you can compress a whole lot more and use ancillary compression therapy for controlling the edema with the venous insufficiency now that you got better arterial flow.
So do you believe that, I'm asking Alec because you're the surgeon in our midst, is that this is just a superficial, this is just communication to the greater saphenous vein, or could be deeper, or this is, how do you describe it, and what needs to be done after this CTO is opened?
Well, first of all, I'd like to commend Dr. Burkett for his very nice hemodynamic description. It's completely true about the effect of these fistulas proximally and distally. I think that if you have a situation of critical ischemia and edema, and that is likely caused or at least exacerbated by that fistula, you have to treat that fistula. You don't need to treat it necessarily today, although certainly putting a Viabon in it and not treating it would make me nervous. You're going to have to treat it at some point. You're going to have to evaluate it better, maybe with an MRI, and probably go through the profunda and identify the feeders and treat them. And you may have to do this in several sittings because these things are very difficult to treat. They come back. But I think you have to treat it to give this patient's foot the best chance to heal.
And one follow-up question, and then we'll go to the panel. What would be the best way? So selective angiography of the profunda, because seriously, I haven't dealt with this, so I can't comment. So your thoughts. Or there are other imaging modalities that could help identify the bigger feeders in this situation.
Well, I think angiography, you would selectively identify the branches, and then you would there usually are several nitises. It may be more. It's just hard to know what we're dealing with. But and then I would put coils at those nitises, and it's very difficult because you want to make sure that the coils don't embolize to the lungs. It's actually a quite complicated procedure.
Dr. Walker, please.
Yeah, Ali, how surprised would you be, however, if once we create outflow and now we have a low resistance runoff, where before we had a very high resistance runoff with all infrapopliteal vessels occluded and the popliteal occluded, how surprised would you be if you saw much less flow in the AV malformation coming from the profunda at this point, now that he's establishing true outflow?
I would actually.
I'm sorry. I know Dr. Walker, but let me ask you a question. So did angioplasty of the TP trunk here? That looks good. The PT
Yeah, it looks
that's
nice.
diffused is, so the PT now looks even better. So the question is that you want me to go after some angioplasty of the PT, or should we try to open the AT, given that the situation?
I think I would go with John's suggestion to you that before you go for the AT, you have two vessel runoff. I would really optimize the SFA stent. I think it is really, very crucial because if you leave it with residual disease, I think the whole idea of producing outflow will not be sufficient.
No, you have to fix now the outflow, and then you can finish with the SFA. So clearly, you need to optimize the posterior tibial, and next step would be to open the anterior. And then you have really unrestricted outflow through all the three vessels, and that's the perfect condition then to finish with the SFA.
So we have two different suggestions. Craig, you had a point, please go
Actually,
ahead.
I agree with
No,
Thomas. I think we just need to do the SFA at the end, but we can get the tibial stuff open completely.
Go ahead, Craig.
Yeah, I agree as well. I would fix all three outflow vessels. Then I'd reassess how much flow we have in AV malformation to determine whether or not this is something we have to do now, or at least make some attempt at now, or stage.
Can use the same balloon as
Yeah, I agree, Craig. I think it's a provocative question about what's going to happen to that flow through the veins there. I predict that it won't change, but we'll see. I don't think it needs to be fixed today at the same sitting.
How many of you have actually done AV fistula coiling in the profunda? I, to be honest, have not done it. So you have done it. So what are some of the issues here? So could you cause damage to the profunda artery itself or thrombose it back. Now that you have, that would be highly undesirable, is that right, to put coils through the profunda? I don't believe it would be such a simple task.
So the profunda is a critically important blood vessel in these patients because it provides critical collaterals to folks so that even if the SFA goes down again, patients do not develop acute limb ischemia.
Sure.
So we do everything possible to protect the profunda. So you can't just put a Armplatzer plug proximally into it. You have to really get down to the smallest possible vessels and try to put coils into those. Identify the nitises. There usually are several, depending on what we're dealing with here.
And what specific coils, because you did mention, because these AV fistulas are quite notorious in terms of changing their size. So embolization of these coils is a tangible and a practical problem. So are there any tips or tricks? Anyone in the audience or in the panel, please?
I'm not thinking coils, I'm thinking more onyx glue, because you got so many small little branches. Just go down in your tertiary branches and kind of see where the greatest contribution is and just put some onyx.
You know, I don't want to say this, but just to say, we just published a recent paper of coronary perforation plugged with subcutaneous fat. We took subcutaneous fat from the patient's groin, and we put it through a introducer and injected it into the distal branch of a diagonal, and it was presented at TCT this year, ACC this year, and also published. So something to think of, but I've never done this in the profunda. But any other ideas, Thomas and Dr. Manzi, John, any other ideas how to deal with this profunda fistula?
Well, basically we use soft coils. There are some offered from different companies like Terumo. They can be placed into bifurcations distally, so this is like onyx more or less. So there are different ways, of course, yeah.
John, have you used subcutaneous fat or don't find it intriguing?
I haven't even thought of the possibility of using subcutaneous fat, so no. So I congratulate you for even thinking of it, but no, I haven't. I think.
Well, we're in Texas. There is a lot of fat. So.
Yeah, everywhere. In a case like this, so I think, as Bruce mentioned, a lot of times things other than coils are better. Particularly onyx or glue, and as long as done by somebody who has experience with using it, it can be very effective and probably more effective for these little AV malformations than coils themselves.
So, Dr. Manzi, you brought up the first idea. I'm not the first, but on the discussion today is to go after the below the knee. So, are you satisfied, or you with Thomas that you want to go for the AT CTO also, which is slightly more, it's not is reasonably doable, but slightly more complex than the peroneal and posterior tibial ones?
Yeah. First, I would check the foot angiogram after this dilatation, and I agree with Thomas. We first have to fix the outflow in the posterior and peroneal, and then we could even think to fix the AT and the SFA. It would be really interesting just to have an imaging guided decision about angiosome and about wound-related artery, if there is really an improvement in blushing around the wound area after this recanalization, because it's crucial to know if we are doing now, it's useful for the patient or will be useful for the patient. So,
Thomas, I have to do a debate on
maybe it's possible to avoid the
concept
anterior
at the upcoming conference. So do you believe in it? Because if we believe strictly by the angiosome, you have already treated the artery that is feeding the ulcer. Do you need to go for the AT right now?
Well, in theory, the angiosome concept is nice, provided if you would have a therapeutic option or modality which guarantees sufficient patency. At the moment, we don't have. And what we have learned is the more arteries you open, the better is the clinical longer-term outcome. So clearly, even if the result after chocolate balloon might look quite nice in the posterior tibial, I would approach the anterior because it's a pretty short occlusion. And if one of those vessels remains patent on the long term, this is clearly beneficial for the patient.
Yeah, I think Dr. Soga's presentation was very elegant in that regard. I think the more you open, the better in terms of achieving wound healing and I mean, these are likely to restenoze, so if you start out with 3 vessels open rather than just one, even though it's the angiosome-related artery, you have a better chance of success.
So I'm going to quote you, gentlemen, on my debate at SCI. So, going back to Mehdi, your chocolate balloon inflations look impressive. And what size do you have right now? Looks like you have a longer one right now.
It's a 3.0 by 120.
Okay.
Can you okay now?
Yes, we can hear you better.
Okay. It's a 3.0 by 120. So we did the TP trunk. We are working on the proximal PT. And then after this, we'll take a couple pictures of the distal tibial and the foot. And then we'll move on to the AT if we think is necessary. I agree with the panel. I think in these situations, especially given that it's short occlusion, it may be worth the dye and the effort to open the AT too. And given the size of the wound, I think there's a lot of factors you got to take into consideration. And one of it is the size of the lesion and the degree of difficulty. There are some collaterals in the AT, so it may not be as easy as one may think, given the number of breathing collaterals that are there. But I think worth at least try.
Wonderful. Alec?
I'm going to and what this looks like.
Go ahead, Alec.
So the only thing to consider is the foot and what the foot looks like, because the pre-interventional foot angiogram shows that the dorsalis pedis was the main vessel to the foot. So I would actually really want to look at the foot and make sure that you've really revascularized the posterior foot. Otherwise, I would definitely intervene on the AT.
Yeah, but he has shown already in the introduction slides that the anterior is a very big artery as we see it here. This is equally important. And even if the flow is pretty good, as mentioned, if we would have a good durable outcome of the PT intervention, I would stay with PT only, but we don't have modalities at the moment that are really persistent. So he has a bigger chance, or the lady has a bigger chance for wound healing if both vessels would be opened. And there's a nice communication.
This is an excellent result right now, Mehdi, and my vote, and if I may just say, is just stop and go for the SFA right now. That's my vote.
No, the PT is not yet perfect. There's still remaining at least 70% stenosis below the area which was treated.
Go down. 1 second.
So Bruce, you go for the
So we're
PT?
gonna try-
I'm trying to draw up some
Yeah,
debate here.
the problem is getting the biggest conduit down there and leaving some stenotic disease behind is going to be problematic, and the patency with that heel wound, you're going to need months. So this PT is going to need to stay open for a long time, and that's the reason I think Dr. Zeller's promoting doing both as well, because if you're going to dilate the whole posterior tibial artery, how long is that thing going to stay open? And
That's a great point.
You're going to want this contralateral AT for the future as well. So I vote to do it. The challenge is, as the vessel, everywhere you dilate now, it looks worse distal to it because
That's right.
you just dilated and made that segment look a lot better. And then using a 3 millimeter balloon all the way down, it looks like this posterior tib distally might handle it, but there's just diffuse disease through this whole thing. So patency here is going to be a real challenge in the long run.
So Thomas, are there any drug-coated balloons in Germany available for the smaller vessels?
There are
balloon for them.
Yeah, there are multiple available, but none of them which is available on the market has shown efficacy so far. So at the moment we have no drug-eluting balloon which has shown any benefit as compared to plain balloon. So we use drug-coated balloons in our institution only within study protocols or in really desperate cases where we believe we have no other option. So maybe the remaining stenosis is just at the proximal edge of the screen, so it's a very short remaining stenosis. If you recap your previous images, you can see it, so it's only a 2 centimeter long residual stenosis which needs additional treatment. Go back 2 or 3 runs, then you will see it.
Yeah, I agree with you. I agree with you. I'm going to do that part. It's right there, right beyond where the balloon. So we just need to get 2 more centimeters. Right there, right there.
Part of it is, though, it's a
I
3
think-
millimeter balloon and a vessel that has a lumen diameter of about 2. So every time, as
Yeah.
Bruce mentioned, you dilate it, it's going to look a little worse right at the distal edge of the dilatation segment.
Dr. Manzi, would you use here at all coronary stents if you need to?
Our experience for below the knee stents is limited to the peroneal trunk area, probably because trying to avoid any bifurcation with the posterior and peroneal. And when we have focal, severely calcified lesions that would need some scaffold, but I really don't believe in below the knee stenting, actually, of course. We were obliged to deploy some stents, maybe no more than 4 or 5 stents in the last 10 years, and the results were very, very bad in terms of fractures, in terms of patency. The recanalization was quite difficult because of the progression of the wire outside of the stent. So I prefer not to avoid any stents deployment in.
So that looked good,
But the
Mehdi.
best.
Actually, better than I thought it was going to look. It's a nice result in the PT.
Mehdi, can you play that angio again?
Yes, I'll play it again.
Sure.
I'm just going to hit that peroneal one more time. Let me just hit the peroneal, go down. Because I think the distal peroneal needs a little bit of work with the 2.5 balloon. So let me just do this and then I'll show you the whole thing.
And you have
Stop
8
like this.
minutes left to the end of the case, so I just want to remind you that.
That's great. Thank you very much. So we're going to balloon the distal peroneal.
And technically,
hit
it
it-
is important you keep things moving. These cases go long and complex, and you just got to keep moving.
Right.
And just keep something moving all the time. Now, with that said, I'd like the anterior tibial artery back, but you don't necessarily have to get it right now. So if you can't wire it easily, then you can. I'm not sure I'd approach it from a retrograde setting right now, but in a short future, and come back and get it another time.
So Mehdi, I know everyone is focused on the below the knee arteries, and I think it is critical, but I am also very interested in the result in the SFA because at least on the last picture I saw, it didn't look perfect to me.
No, we're going to have to do DCB we're going to be using DCB of the SFA, and I'm going to be using, with the DCB, we try to size 1-to-1, if not even larger, to be honest with you. That's what we have learned.
Sure.
And we can discuss one, but we're going to do a DCB of the proximal SFA, and then we reassess the situation. I think that if you recall the angiogram, it didn't look that bad. I think it may be amenable. So I'm just going to overlap the Viobond with the DCB and place 2 DCBs in the proximal SFA and take care of the proximal SFA with the 2 DCBs like that.
Yeah,
Let me give you a picture.
Dr. Manzi mentioned, please also focus at the origin of the SFA, at the very proximal segment. There seemed to be some disease there, which was not very clear, at least on the angiograms we looked at here.
Absolutely right. He's absolutely right. And we need to address that with the DCB all the way to the ostium.
Very
So
nice.
here's the
And you're
picture.
keeping it up 3 minutes, I'm guessing?
About a minute and a half.
So we are looking
know
intently
if
at
you
this
can-
angiogram. There is a
that's a
proximal dissection in the peroneal, in the posterior tibial, but I think the flow
Yes.
is very good, and you may decide to either balloon it one more time or just leave it. Otherwise, you're going to have to stent this very soon.
Well, it's interesting because when we started earlier, you looked good.
Yes.
I think somebody meant it. So when we did it earlier here, it looked good, but see that here?
Yeah, I
It
do
looked
see
pretty
that.
good here. Yeah, and now that we took out the wire and we went down the other branch, to be honest with you, my own feeling, I don't want to go, I think that we need to, and look at here, here it looked beautiful. I
Yeah,
wonder if some of that is,
I think dye stains in smaller vessels look slightly worse when the vessel actually recoils because the dye stain stays on the outside. So that's probably is happening here. But I think the flow is very good, and you don't. I personally would if I were the operator, I would at this point leave it alone and take some more pictures. It's looking worse now, actually.
What did the panel think? Because I mean, one option is to put a DES there is necessary.
Or give some
The other
vasodilator maybe.
Well, I think you can work on the intertibial, fix that, and you can fix the SFA, and then, give it a little bit more time. And if it looks the same at the end of the
Agreed.
case, I'd probably leave it alone. If it starts looking worse, then I'd go back and retreat the PT and maybe stent it.
I agree. I think John's practical suggestion is to go for the AT and take a final picture and maybe later see if you need to stent it. But
John, if you were to stent it, what type of stent would you use?
Size, I'd probably use a coronary DES and probably a 3.0 coronary DES there. Probably a long one, like a 38, Science or Synergy.
Can I get some more saline here?
Is there any DS in the US approved for below the knee use?
No.
No. Because in Europe, the Promos and also the Science, they have below the knee approval.
Do you actually get reimbursed when you use them?
No, but they are so cheap, so they are not more expensive, not significantly more expensive than bare metal stents for below the knee, so there is no big difference.
so maybe in the nearly 4 minutes, you're going to attempt to cross the AT occlusion, seems like, and you have the same equipment, or you have still with the pilot?
Have same equipment. Come down a little bit. Yeah, come down. So we are in the proximal AT, so we're going to get inside and then reposition our wires because it's in a branch.
Yeah.
Okay?
It's pretty cheap. Yeah.
So let us see what we have here.
We have even contracts with some
Now,
companies
what
for
is that we don't have a lot of support here.
So 3 minutes seems like plenty of time to finish this case.
And I agree with Bruce that, we have to be careful there. So it crossed nicely, we got lucky today. But it crossed nicely. So go down with the balloonless balloon.
Great work, by the way. Great work.
Okay, that's good. Okay, so we can inflate down.
And this
So
is the chocolate
sometimes-
balloon still?
We changed it to a 2.5. So after this 2.5, we'll do the chocolate. But for the sake of time, I just kept this balloon so that at least I can show you the angiogram of the AT. By the way, the advantages of the live fixes are that you work efficiently. I gotta give them at least, that's one advantage. We don't waste time talking and joking around.
That's true. Okay, that's enough. You can come down. We are eager to see the angio. It's 2 minutes and 14 seconds left, so.
The good thing is that we are not in the live, these are not satellite transmissions, so if we go a few minutes over, it may be okay. I know we have satellite symposiums, but we may be able to go 5 minutes over. If that's okay with you. So we can at least give you guys some final picture.
For you, we will sacrifice 3 minutes of our lunch break, but go ahead.
Thank you very much.
Are you presenting at the lunch symposium?
Okay.
No.
So I'm going to come down with this and then
Session together.
Oh, yeah.
Access.
Okay.
Wonderful.
I think we have a nice 3 vessel at least. There's some recoil in some areas, but I think we have given her a lot of volume here. So hopefully, with this, there should be significant healing. So let me move now. I think we saw the foot picture. I think this looks good. The rest of the AT looks good. I can take one more picture if you want, but I wanted to show you the proximal SFA
Yes.
in the next couple minutes that we have here. I'll show one more picture here so you can see the runoff, but I think it looks pretty good. Any?
good.
So maybe
He's
did
getting a
you,
little bit of
yeah, did you
Like-
inject some nitro? Because it seems that all the areas you did touch with balloon, even if it was the chocolate balloon, tend
Yeah,
to
some
create some
nit-
recoil.
Yes, I agree with you. I think exactly what's happening. I'm going to give some nitro, but while they're getting the nitro, let me show you the proximal SFA so we can see what you guys think.
Sure.
And then we can go off air. We can finish the rest of it off air here with a couple DCBs. So we give some nitro. Let me show you a couple pictures of the proximal SFA. Can you put this on? So let me give a little bit of nitro here. I got 200 of nitro, 400 of nitro. Can you make sure fluid is wide open? All right. So let me give you a couple pictures of the proximal SFA so we can make some decisions.
Sure.
At least you guys can help.
And we
Extra
can
very
angle
good.
it a little bit.
One question for my understanding. I see markers. Are you using wire bands with markers? We don't have them in Europe. I'm not aware of.
The new.
They have a little bit of a marker at tip. So here is the SFA. That's the ostium right there. We get a better picture of that. I can angulate it more.
Not bad.
But then the
That's
rest
good.
is, and then we have that area that was the occlusion, I think, that is now more dissected. So that may require a stent. So maybe what we do is that we put a silver in that area. Let me get a picture of the mid SFA. Go ahead.
So
So you
Thomas,
see the Viobond.
the new Viobonds have markers, at least in
Okay.
US.
So is this the 18,000 Skywire compatible version? Or? Yeah, okay.
Yes.
So what do you guys think? What do you think we should treat the SFA with? So we have that, this area is very protected. So I'm thinking, the options are, I don't think we're going to get away with DCB. What do you think?
My personal vote is to stent this, and my personal vote is to put more Viobonds.
Exactly,
We have
because
very little time, so
Yeah,
just.
I would agree.
There is a little fistula there that you want to
Dr.
cover. I
Manzi,
think.
you? No more stenting?
Another Viobond.
Dr. Manzi says no.
Prolonged inflation.
Prolonged inflation. Bruce?
Vibond extension.
Thomas?
yeah, definitely, because there are two branches which are providing the AV fistula. So this is the area which I would have covered initially with the wire band, to be honest.
John?
Well, in all respect to my colleague, Dr. Manzi, I would put in the stent. I put in the cover to stent here.
Anyone in the audience? I think extending the Viobond, I initially said should be long, so I think that might be the most prudent and time-saving approach here also. So we are all for putting more Viobonds. Mehdi, do you have more?
Yes, we actually do have one more. Dr. Leiden keeps us under tight control, but we have a couple left, yes. So we're going to put a Viobond here. We have another 6 by 150. And maybe I can show the deployment on this one. They're relatively easy. And I'm sure most people have used it in the audience. But
So
just to show it-
if we get cut off, I just want to summarize what you said. You are going to place another Viobond, and if I caught you correctly, you did also say that you are going to use a DCB to dilate the distal edge of the Viobond. Is that correct?
No, proximal.
Yes.
Proximal?
The proximal, yeah.
Proximal, not the distal.
I can hear Dr. Leiden grumbling all the way down here from the hospital.
So let me ask you, how much overlap do you usually do with the Viobond? I'm interested in the panel take on this.
Few millimeters. This is very accurate with the marker, so I don't go that far unless you have oversized the length.
Several millimeters.
Dr. Manzi, lot of overlap, little overlap? Does it matter?
Just half centimeters, no more than one.
No more than 1 centimeter. Bruce?
2 or 3 millimeters is enough.
So short. So Thomas also short?
Yeah, well, in a range of up to 1 centimeter, so 5 to 10 millimeters. This is what
Fine.
I usually do.
Bruce?
1 by 5. 6 by
Unless
5
you're
and
putting
6
them
by
in a
10.
Oh, I'm sorry,
popliteal
John.
aneurysm, and then you would have a lot of overlap because
Yeah.
they can separate. I mean, there is some movement, obviously, so if you don't overlap more than a couple millimeters, there could be some separation over time. So I would, do about 5 millimeters.
It's too short,
I
unfortunately.
have not been using DCBs after wire bonds, but it seems like an interesting idea. Bruce, have you been?
Maybe you need a third one.
Yes, you need more wire bond. But Bruce, DCB after wire bond?
Yeah, haven't used it routinely. Usually cover disease-free segment to disease-free segment is the basic concept.
Dr. Burkhardt, one of your slides needs a revision. You had to add more cost to it. $3,500 for wire bonds, 3, and then DCBs to post-dilate. Your comments?
Yeah, but from a hospital standpoint, the Viabonds take away from your profit margin, whereas the DCBs are reimbursed dollar for dollar. So, if Sean Leiden's going to come down the hall, it's going to be about the Viabonds, not about the DCBs.
Point well taken. It is looking good. So another stent here, Mary, quickly.
No, so we go now. We're going with the DCB now. So we have a 6 by 120 impact DCB, and we're going to go there. Right there is good, yeah. So we're going to go up with this. So we are.
So Alec has a comment regarding DCB use.
No, I was just going to say that I'm not sure if it's necessary, but I can't argue with using it.
I agree.
So you're saying that you.
No, Alec doesn't see the reason. I agree with using it, but I would use it slightly more distally, at a distal edge, not so much more proximally. The vessel looks to me proximally better. I'm more worried about the distal apposition and the distal disease.
I mean, we posted the Viabond distally, so from a post standpoint, can you show this picture for 1 second? Just for 1 second, if you can. Can you? So the distal popliteal, I'm having them show it you. It doesn't look that bad, so, and we posted it with a 6.0. The proximal has diffuse disease, so I guess the concern always is that, we have 2 areas that we need to deal with when we are dealing with Viabond, flow and the outflow. Because if you have bad outflow, you can thrombose. If you have bad inflow, you're going to thrombose. So both inflow and outflow are important in my opinion. And in this situation, given that we posted the distal and it looks good, okay, you can go back. Looks good. We decided to hit the proximal, because the other option here, silver pit, or I don't can go angioplasty that now available and head to head of
Mehdi, you are breaking up significantly, so we will just watch you as you do the final pictures.
You guys are. Okay, that's 2 minutes so far.
As we do more and more DCB, and I routinely do 3-minute inflations with my drug-coated balloons, we see how much better angioplasty results we get, with prolonged inflations. It's quite remarkable how good it'll look after DCB when you do that 3-minute inflation.
I agree. That is why I brought that up, the 3-minute issue. I used to do very shorter, much shorter, but I think more and more experience from people like yourself and others clearly have demonstrated that longer inflations produce better and more durable results. Bruce, you have a comment on that? I saw that you're making the same point.
I couldn't agree more. It's just, it makes a difference.
That's very nice, Mehdi. Very nice work.
I think we are done here. I think this proximal area looks good. That's the proximal area. We hit it with a DCP 6.0. I think we have a nice, I don't know if you can hear me or not. I apologize for the connection. But thank you very much and enjoy your lunch.
Thank you very much. Thank you to the entire panel and to all the audience for their participation.